Our group members are Annika, Bailey, Brianna, Christina, Chloe, and Nicole, and our presentation is focusing on type 2 diabetes. So type 2 diabetes is a chronic condition in which the body is unable to regulate blood glucose levels due to the inability to properly use or to properly produce enough insulin, which is a hormone that helps move glucose from the blood into the cells. The two main types of diabetes are type 1 and type 2, and this table highlights the main differences. Where type 1 diabetes is caused by failure of the pancreatic beta cells to produce insulin, type 2 is a combination of insulin resistance, incretin dysfunction, and abnormal hepatic glucogenesis. For type 1 diabetes, the age of onset is typically less than 30, the symptoms appear more abruptly, the body weight remains fairly unchanged, and there's little to no insulin in the blood. Whereas in type 2 diabetes, the age of onset is typically older than 40, the symptoms appear more gradually, and around 80% of the people with type 2 diabetes are obese. In type 2 diabetes, there is also usually enough insulin present in the blood to prevent diabetic ketoacidosis.
HHNS is severely high blood sugar levels and an increased serum osmolality with dehydration without the presence of ketones. Usually the kidneys play a role in compensating for the elevated glucose in the blood by getting rid of it through urine. But this condition causes the depletion of intravascular volume, so the kidneys have a limited ability to excrete these large quantities of glucose, causing a decreased renal perfusion. As a result, the body now has to hold on to all this extra glucose. An increased serum osmolality in the extracellular fluid produces a shift of water into the intracellular space, causing dehydration inside the cell. This shifting of water lowers the serum sodium and expands the extracellular fluid volume. DKA is rare in type 2 diabetes, but it can still occur and affect the fluid and electrolyte balance in patients with diabetes. This develops when the body cannot produce enough insulin, causing breakdown of fat as fuel, causing a buildup of acids in the bloodstream. Hyperglycemia, osmotic diuresis, and metabolic acidosis contribute to the electrolyte imbalances. The fluid shifts from the intracellular to extracellular space, causing fluid deficits, and you would get electrolyte disturbances such as hyponatremia and hypokalemia.
There are two graphs shown on the slide above. One being incidence. 90% of diabetes cases in Canada are type 2 diabetes. Statistics show that in 2014, 8.1%, which is approximately 3 million residents in Canada, were living with diabetes. For prevalence, the highest prevalence of type 2 diabetes is in the 80 to 84 age range. As the graph shows, the prevalence of diabetes is higher in men than women, and the prevalence of diabetes increases with age. For demographics, it's more common in men. It's more commonly seen in the older population from 55 to 85. It is 3 to 5 times more common in First Nations populations and in the lower income and overweight populations.
The causes of diabetes type 2. Genetics is the first one. Obese individuals have a genetic predisposition to beta cell dysfunction. The second cause is lifestyle, lack of exercise, poor food choices, and being overweight. As people's body mass index increases, the risk of developing type 2 diabetes increases by 90%. Additionally, obesity has effects on the sensitivity of insulin. What are the risk factors for the disease? Obesity is the number one risk factor, specifically abdominal obesity. High-risk populations: Indigenous, Latin American, South Asian, Asian, African, vascular disease, gestational diabetes, hypertension, history of delivering an infant with macrosomia, hypertension, dyslipidemia, polycystic ovary syndrome, and darkening under the armpits. For the pathophysiology of type 2 diabetes, there are 4 metabolic abnormalities that have a role in the development of type 2 diabetes, one being insulin resistance. This means the body does not respond to insulin, and the insulin receptors are unresponsive to the action of insulin. The second one is a decrease in the ability for the pancreas to produce adequate amounts of insulin. This occurs because the beta cells become fatigued due to the overproduction of insulin, or when beta cell mass is lost. The third one is the liver produces inappropriate amounts of glucose. This results in an increased blood sugar and inappropriate regulation of glucose production. The liver does not release what the body needs. This also leads to an increase of blood sugar levels. The last abnormality is alteration in the production of hormones and cytokines by adipose tissue. It is believed that adipose cytokines play a significant role in glucose and fat metabolism. Adiponectin and leptin are the 2 adipose cytokines that impact insulin sensitivity.
The symptoms of type 2 diabetes are nonspecific and often mild, which is why they can go undetected or disregarded for a long period of time. Feelings of fatigue and hunger can arise because the body can't use food for energy as effectively as it should. This is because glucose can't enter the cells due to either a lack of insulin or insulin resistance. In type 2 diabetes, sugar builds up in the blood, and to compensate, the body pulls fluid from tissues and thus increases the workload of the kidneys. This results in increased thirst and urination, and possibly dehydration, which then leads to dry mouth. High blood glucose levels can cause the skin to dry out, which is why people may report itchy skin. This increased blood glucose levels can also cause damage to the nerves and blood vessels, which is the reasoning for the sensation changes in one's feet and erectile dysfunction. Reduced vision is also a result of high blood glucose levels because it can inhibit the eye's ability to focus. Headache is also correlated to out-of-range blood glucose levels, but they can arise when levels are high or low. Moving on to the signs of type 2 diabetes, unexplained weight loss can happen due to losing calories and sugar, relating back to poor nutrient absorption and increased urination. Recurrent infections can occur because high blood glucose levels hinder the immune system. These infections are most common in the urinary tract, oral cavity, skin, and genital areas. Infections of the oral cavity explain why tender, red, swollen gums are also sometimes apparent, but these gum changes can also be due to the symptom of dry mouth. Poor wound healing can be reported, and this is due to poor circulation. The picture on this slide shows acanthosis nigricans, which is a velvety skin discoloration that can indicate insulin resistance. These patches are commonly found around the neck, armpit, and groin. Lastly, one could lose consciousness when blood glucose levels drop too low. This can occur after skipping a meal, exercising, or taking too much medication. Unfortunately, damage from these signs and symptoms can occur even before signs and symptoms become noticeable. This is why early recognition is so important, because we want to get the disease under control and prevent these damages from happening. There are 4 methods used to diagnose diabetes, and the values listed indicate a positive diagnosis. However, one of these tests need to be repeated in order to confirm the diagnosis, and hopefully the same one is done but on a different day. Fasting means no caloric intake, and random means at any time of the day without regard to last meal. The A1C test is also a great representation of blood glucose levels over time. It shows how much glucose is attached to hemoglobin, which is attached to red blood cells. This picture on the side shows that. Because the life of a red blood cell is about 120 days, this test shows how well glucose levels have been controlled for the past 90 to 120 days. If someone has diabetes mellitus, they should get their A1C tested every 3 to 6 months. If they manage to achieve an A1C of less than 7, they have an increased risk of developing complications.
Some people with type 2 diabetes are able to manage their blood sugars through lifestyle factors alone. Diabetes Canada states that daily physical activity can be as beneficial as some medications in lowering blood sugar. This is because muscle activation requires uptake of glucose, thus preventing it from building up in the blood. Additionally, it burns calories and aids in weight management. If the patient is on insulin-increasing medications, educate them to check their blood sugar before, during, and after activity, and to keep a quick-acting carbohydrate on hand to combat potential low blood sugars. Adopting a nutritious diet is another beneficial intervention. Working with a dietitian to create an individualized meal plan would be beneficial here. Focusing on foods low on the glycemic index, meal planning to maintain consistency, and carb counting are all tools that can contribute to maintaining steady blood glucose levels through diet. A healthy weight lowers the risk of developing complications. Reducing initial weight by 5 to 10% is shown to improve insulin sensitivity, lower hepatic glucose release, improve blood pressure, and lipid profiles. Smoking cessation has a big impact because, like high blood glucose levels, smoking contributes to damage of blood vessels, which therefore increases risk of developing complications. Ensure to educate and discuss the importance of adopting a healthy lifestyle with your patients. If target blood glucose levels are not met through lifestyle factors, medications will be introduced. Patients will typically start on the biguanide metformin. It is the first-line treatment. It works by making the body more sensitive to insulin, reducing absorption of glucose in the gut, and decreasing hepatic glucose production. If needed, additional medications may be introduced. Alpha-glucosidase inhibitors prevent glucose absorption from the digestive system. GLP-1 agonists mimic the action of GLP-1 incretin hormone, increasing insulin levels by stimulating the beta cells of the pancreas and inhibiting glucose release from the liver by lowering glucagon levels. We can use DPP-4 antagonists to inhibit the DPP-4 enzyme and in turn extend the glucose-lowering action of naturally occurring GLP-1. SLT2 inhibitors inhibit the action of sodium glucose cotransporter 2, whose job is to regulate reabsorption of glucose in the kidneys. When it is inhibited, the excretion of glucose in the urine is increased. Insulin secretagogues stimulate beta cells in the pancreas to increase insulin release. And finally, thiazolidinedioxide nodes increase insulin sensitivity in adipose muscle and liver cells. We want to teach the patient how to monitor and interpret their own blood glucose levels and educate them on how their medications work and when to take them so they can successfully adhere to their medication protocol and understand how doing so prevents the development of complications. Insulin therapy may be necessary if blood glucose levels are not managed by anti-diabetic medications and the pancreas is not producing adequate amounts of insulin. When administering insulin, it is important to properly follow the protocol for your patient and know the onset, peak, and duration of their insulin so you can assess the effects accordingly. This information you can see listed on this slide. Remember to rotate injection sites and educate the patient how to safely administer their own insulin. With any treatment that increases insulin levels, it is important to be aware of the risk for hypoglycemia. A relatively new treatment are extended-release GLP-1 agonists. These can have a positive effect on medication compliance and the patient's perceived quality of life, as they only need to be administered once weekly. Bariatric surgery has also shown success in remission of type 2 diabetes and can be an option for those who are unable to manage the condition despite lifestyle and pharmaceutical efforts. However, it requires more research before being recognized as a primary treatment option. The nurse's role in treatment of type 2 diabetes includes monitoring blood glucose and maintaining stable levels, safely administering medication, and assessing and addressing complications. Complications will be further discussed in the following section of this presentation. Additionally, as touched on throughout the treatment and intervention section, it is so important to educate the patient. Assessing the patient's education needs and providing teaching enables them to actively participate in their own care, successfully manage their condition, and reduce their risk of developing complications. Nurses should also utilize expertise from the interdisciplinary team in order to best assist the patient at meeting their individual needs.
Some of the most common complications of type 2 diabetes are neuropathy, slow wound healing, kidney damage, diabetic retinopathy, atherosclerosis, hyperglycemia, and hypoglycemia. So the neuropathy is a type of nerve damage that occurs when high blood glucose levels are not effectively controlled. The high blood sugars damage peripheral nerves and interfere with their ability to send signals and weaken the walls of the small blood vessels that supply the nerves with oxygen and nutrients. Slow wound healing is a result of both the high blood glucose levels and neuropathy. There's decreased blood circulation, which makes it hard to get the blood to where it's needed. The wounds are sores. So diabetic foot ulcers and sometimes amputation are complications. Kidney damage is when the kidneys are damaged and cannot filter blood effectively. Inside the kidneys, there are small blood vessels that play a role in filtering blood. When diabetes is uncontrolled and the blood sugars are consistently elevated, this causes them to start to narrow and get clogged. Since the kidneys are not able to filter, albumin passes through these filters and ends up in urine, which is abnormal. The nerves in the body become damaged, and the body is not able to recognize when the bladder is full. This pressure inside the bladder causes damage to the kidneys and further causes a UTI. Atherosclerosis is the hardening and buildup of plaque in the coronary arteries. This buildup of cholesterol normally supplies oxygen and nutrients to the heart, but these plaques causes the arteries to narrow, which decreases blood flow. Atherosclerosis can become a complication of diabetes due to the prolonged increase in blood sugar levels that change the blood chemistry and reduce levels of vasodilators in the blood vessels. If these plaques rupture, the body attempts to repair it by sending platelets. These platelets can further block the blood flow of the heart and contribute to a heart attack. Those with diabetes are also at a higher risk for developing heart failure, where the heart isn't able to pump the blood effectively. With the decreased blood flow going to the brain, this can cause a stroke to occur. The most lethal complications are HHNS, cardiovascular disease, and kidney disease. The definitions are stated on the PowerPoint. For the patho, HHNS, if not treated away, can progress to seizures, coma, or death. As well, it can cause shock, blood clot formation, cerebral edema, and increased lactic acid levels. These can occur due to the imbalance of fluids, glucose, and minerals in the body caused by hyperglycemia, dehydration, and the kidney's decreased filtering ability. These elevated glucose levels impair endothelial functioning and contribute to the mechanism of strokes. Kidneys lose their filtering ability, and they have dangerous levels of electrolytes, waste, and body fluids that accumulate in the body. Without treatment, it can continue to get worse and cause the kidneys to stop working, which is life-threatening. Complications that you should be most concerned about are blood glucose imbalances like hypoglycemia, hyperglycemia, HHNS, and then cardiovascular disease. So with hypoglycemia and hyperglycemia, the main takeaway is hyperglycemia is the 3 Ps, polyuria, polydipsia, polyphagia, and hypo would be shaky, dizzy, sweating, confusion, both monitoring by blood glucose. And hypo, you would do an oral ingestion of a carbohydrate or glucose tablet. Hyperglycemia, you would do an insulin correction dose. HHNS is life-threatening, so it would be dry mouth, elevated blood sugar levels, extreme thirst, hallucinations. You would want to diagnose through plasma glucose, serum osmolality, a BUN and creatinine, and sodium levels and ketone test. You would use electrolyte replacements, fluid replacements, and insulin therapy as needed. Cardiovascular disease can have many symptoms, but the main one is chest pain, shortness of breath, numbness, weakness, etc. Diagnosis, there's lots. And then treatment, lifestyle changes, medications like beta blockers, nitro, and then surgery if needed.
So what is the most recent best practice or evidence-based practice with type 2 diabetes? Healthy lifestyle choices are the first recommended treatment. This includes a low-fat, low-sugar diet, increasing your vegetables, and increasing your exercise. I'm also going to evaluate the A1C test for diagnosing. Equal or greater to 7 indicates diabetes. Anti-hyperglycemic medications are combined with these healthy life choices. Metformin is the initial medication of choice unless there's chronic kidney disease or liver failure. Best practice is to monitor before meals and at bedtime in people who are eating every 4 hours if you're not eating, or receiving TPN if you're in the hospital, and hourly if you are on a continuous IV insulin therapy or are critically ill. Following the hypoglycemia protocol in the workplace is very important. So this includes monitoring for people who are symptomatic. So if they're diaphoretic, increased hunger, agitation, tachycardia, decreased LOC, or if they have a blood glucose less than 4, you give the fast-acting carbohydrate, which is any sugar. Check blood glucose in 15 minutes. And once it's greater than 4, you'll give a protein such as a milk with peanut butter, crackers, cheese, and best practice if they can't swallow, then you're going to be giving the IM glucagon. How has research changed the management of this condition? More research has been done in relation to the strict blood glucose control post-operatively. This just decreases the risk of infection, and so for minor or moderate surgeries, studies have shown that the desired blood glucose range is 5 to 11. I've also seen other studies that say the target blood glucose is below 8.3. This does increase your risk of hypoglycemia, but infection rates have been seen to decrease immensely. Also using multiple interventions. So like I said, healthy lifestyle and medications at the same time are most effective. And so ongoing research, there's lots of ongoing research associated with ethnicity, age, and gender. As well, cannabis is more popular these days, and with the legalization, more people are using it. And so there is a lot more research right now being done to determine how cannabis is affecting blood glucose levels, as well as the glucagon-like peptide 1 receptor is being researched for the treatment of type 2 diabetes, and that's just the protein on the beta cells, and it kind of directs the pancreas to produce more insulin, which will control your blood glucose levels.